Folic acid, vitamin B9, and vitamin B12 have closely related roles, especially in DNA synthesis, red blood cell formation, and the proper functioning of the nervous system. Here are the key aspects of their interactions. 1. Synergistic role in DNA synthesis. Both folic acid and vitamin B12 are essential for the conversion of homocysteine to methionine, a crucial step in DNA synthesis. Vitamin B12 acts as a cofactor for methionine synthase, which requires folate as 5-methyl tetrahydrofolate, 5-MTHF, to function properly. A deficiency in either vitamin can disrupt this pathway, leading to megaloblastic anemia. 2. Masking of vitamin B12 deficiency. High doses of folic acid can correct the anemia caused by a vitamin B12 deficiency but will not address neurological symptoms. This masking can delay the diagnosis of vitamin B12 deficiency, potentially leading to irreversible nerve damage. For this reason, it's recommended to ensure adequate vitamin B12 levels when supplementing with high doses of folic acid, especially in older adults who are at a higher risk of vitamin B12 deficiency. 3. Homocysteine metabolism. Both vitamins play a role in reducing homocysteine levels. Elevated homocysteine is associated with cardiovascular risk, and supplementation with folic acid and vitamin B12 can help lower these levels, thus reducing cardiovascular risks. 4. Neurological health. Vitamin B12 is crucial for maintaining the myelin sheath around nerves, and a deficiency can lead to neurological symptoms such as tingling, numbness, and even cognitive impairments. Folic acid does not substitute for these functions, highlighting the importance of maintaining balanced levels of both. Ensuring a balanced intake of both folic acid and vitamin B12 is vital for proper health, particularly when supplementing, as their functions are interdependent. Supplementing with folic acid alone, without adequate vitamin B12, carries certain risks, particularly due to the close interplay between these vitamins in metabolic processes. Here are the main risks associated with folic acid supplementation without concurrent vitamin B12. 1. Masking vitamin B12 deficiency. Corrects anemia but not neurological symptoms. Folic acid can correct the hematologic manifestations, such as megaloblastic anemia, of vitamin B12 deficiency, which can lead to a misleading improvement in blood counts. This may mask an underlying B12 deficiency. Delayed diagnosis and treatment. Since the anemia symptoms improve, a vitamin B12 deficiency might go undetected for a longer period, delaying diagnosis. Meanwhile, the neurological damage caused by vitamin B12 deficiency can progress. 2. Irreversible neurological damage. Progression of neuropathy. Without sufficient vitamin B12, the maintenance of the myelin sheath around nerves is compromised, potentially leading to neuropathy, paresthesia, and in severe cases, cognitive impairment or even dementia. Potentially permanent effects. If a vitamin B12 deficiency is not identified early, the resulting nerve damage could become permanent, even after correcting the deficiency later on. 3. Increased risk of cognitive decline in older adults. Older adults are particularly at risk for vitamin B12 deficiency due to factors like reduced gastric acid production, which affects B12 absorption. Folic acid supplementation without addressing vitamin B12 levels in this group can thus increase the risk of cognitive decline or worsen existing cognitive symptoms. Number 4. Potential cardiovascular risks. Vitamin B12 and folic acid both help metabolize homocysteine, an amino acid linked to cardiovascular risk. Supplementing with folic acid without addressing a B12 deficiency may not sufficiently reduce homocysteine levels, potentially diminishing the cardiovascular benefits of folate. Given these risks, it is generally recommended that folic acid supplementation, especially at higher doses, be paired with a sufficient intake of vitamin B12. This helps ensure that the potential masking effects of folate do not conceal a B12 deficiency, allowing for better management of both vitamins and their related functions. The choice between oral and intramuscular IM vitamin B12 supplementation depends on factors like the severity of the deficiency, absorption issues, and patient preference. Here's a comparison between the two. 1. Absorption and efficacy. Oral vitamin B12. Mechanism. Vitamin B12 from oral supplements is absorbed in the ileum through binding with intrinsic factor, a protein produced in the stomach. A smaller fraction, about 1 to 2%, is absorbed passively without the need for intrinsic factor. Effective for mild to moderate deficiency. Oral B12 supplements can be effective for those with mild to moderate deficiency or those with normal absorption capacity, such as people with dietary B12 deficiency, e.g., vegetarians or vegans. High doses, higher doses, e.g., 1,000 to 2,000 milligrams daily, are often recommended to compensate for the limited passive absorption, especially in cases of malabsorption. Intramuscular vitamin B12 mechanism. IM injections bypass the gastrointestinal tract and deliver B12 directly into the bloodstream, making absorption independent of intrinsic factor and gastric conditions. Preferred for severe deficiency or malabsorption. IM injections are typically the first choice for patients with severe vitamin B12 deficiency, those with conditions like pernicious anemia, gastrointestinal surgeries, e.g., gastric bypass, or severe malabsorption disorders, e.g., celiac disease or Crohn's disease. Rapid response. IM injections can rapidly correct B12 levels and are used to quickly resolve symptoms like severe anemia or neurological impairment. MAPR 2. Convenience and compliance. Oral vitamin B12. Convenient and non-invasive. Oral supplements are easier to administer, non-invasive, and can be taken daily at home. Compliance. Suitable for patients who prefer to avoid injections or those who have a phobia of needles. Cost-effective. Typically, oral B12 supplements are less expensive than regular IM injections. IM vitamin B12. Invasive and requires medical visits. IM injections may require visits to a healthcare provider, although some patients or caregivers can be trained to administer them at home. Less frequent dosing. After an initial loading phase, e.g., weekly injections for 6 to 8 weeks, maintenance doses are often needed less frequently, e.g., monthly, which can be convenient for long-term management. NAR 3. Use cases. Oral supplementation. Suitable for individuals with dietary insufficiency or mild absorption issues. Can be used for maintenance therapy after correction of a deficiency with IM injections. Effective for those without significant gastrointestinal issues or intrinsic factor deficiency. IM supplementation. Preferred for those with significant malabsorption, e.g., pernicious anemia, GI surgeries. Effective in patients with neurological symptoms due to a more rapid rise in B12 levels. Often used as initial therapy for severe deficiency, followed by a switch to oral supplements for long-term maintenance. Summary. Both oral and IM vitamin B12 supplementation can effectively correct deficiencies, but IM injections are favored for rapid correction in severe cases or when absorption through the gut is compromised. Oral supplementation is a suitable, non-invasive option for those with milder deficiencies or for maintenance therapy. Sublingual vitamin B12 supplements are an alternative to both oral and intramuscular IM forms, with the potential for easier administration and improved absorption. Here's how sublingual supplementation compares and whether it can substitute IM injections. Sublingual vitamin B12, mechanism and absorption. Administration. Sublingual supplements are placed under the tongue where they dissolve and are absorbed through the mucous membranes directly into the bloodstream. Absorption efficiency. While sublingual absorption bypasses the digestive system to some extent, the main benefit over standard oral tablets is convenience rather than significantly better absorption. Some B12 will still be swallowed and absorbed through the gastrointestinal tract. Effectiveness. Sublingual forms may be advantageous for individuals with digestive issues like reduced intrinsic factor or altered gastric pH, but are generally considered to have similar efficacy to high-dose oral supplements. Comparing sublingual and IM vitamin B12. Suitability for different conditions. Mild to moderate deficiency. Sublingual B12 can be effective for those with mild to moderate vitamin B12 deficiency, especially when issues like intrinsic factor deficiency are not severe. High doses, e.g., 1,000 milligrams daily, can raise B12 levels effectively. Severe deficiency or malabsorption. For patients with conditions like pernicious anemia, severe gastrointestinal disorders, or those who have undergone gastric or intestinal surgery, IM injections are often preferred initially. This is because IM injections provide a guaranteed, rapid increase in B12 levels, bypassing the need for any absorption through the digestive system. Patient preference and compliance. Sublingual supplements. They are easy to take, non invasive, and suitable for those who have difficulty swallowing pills or prefer to avoid injections. IM injections. While more invasive, they offer the advantage of less frequent dosing after the initial correction phase, which might be more convenient for some patients. Clinical evidence on sublingual versus IM. Similar efficacy. Some studies have shown that high-dose sublingual or oral vitamin B12 supplements can achieve similar serum B12 levels as IM injections in certain cases of deficiency. This has led to the acceptance of sublingual or high-dose oral therapy as an alternative to IM injections for maintenance therapy or even initial therapy in non-severe cases. Patient choice. Sublingual supplementation can be a viable alternative for those with mild absorption issues who prefer non-invasive options or who cannot access IM injections easily. Conclusion. Can sublingual B12 substitute IM? Yes, in certain situations. Sublingual vitamin B12 can be an effective substitute for IM injections in cases of mild to moderate deficiency or as a maintenance therapy after initial correction with IM injections. Not always for severe deficiency. For severe deficiencies, or in patients with conditions that drastically impair B12 absorption, e.g., pernicious anemia, gastrointestinal surgeries, IM injections are typically more reliable for rapidly normalizing levels. Overall, sublingual vitamin B12 is a convenient and effective option, but its use as a substitute for IM injections should be based on the severity of the deficiency and the underlying cause. Yes, routine vitamin B12 supplementation is generally necessary for vegans. This is because vitamin B12 is primarily found in animal derived foods, and without supplementation, vegans are at a high risk of developing a deficiency. Here are the key reasons why vitamin B12 supplementation is important for those following a vegan diet. 1. Sources of vitamin B12. Natural sources. Vitamin B12 is naturally found in significant amounts only in animal-based foods such as meat, dairy, eggs, and fish. It is produced by microorganisms in the digestive tracts of animals and becomes part of their tissues. Plant-based foods. Plant-based foods do not naturally contain vitamin B12 unless they are fortified. Some fermented foods, seaweed, or mushrooms may have trace amounts, but these are not reliable sources for meeting daily requirements. 2. Health risks of B12 deficiency in vegans. Neurological symptoms. Vitamin B12 is crucial for nerve function. Deficiency can cause symptoms like tingling, numbness, memory issues, and even more severe neurological impairments over time. Megaloblastic anemia. B12 is needed for red blood cell production. A deficiency can lead to megaloblastic anemia, characterized by fatigue, weakness, and pallor. Potential long-term effects. If left untreated, vitamin B12 deficiency can cause irreversible nerve damage, making early and routine supplementation critical. 3. Recommended supplementation for vegans. Daily supplements. Vegans are advised to take a daily vitamin B12 supplement of around 250 to 500 millisgrams, which is enough to maintain adequate B12 levels. Weekly high-dose options. Alternatively, vegans can take a higher dose B12 supplement, such as 1,000 to 2,000 milligrams, 2 to 3 times a week. Fortified foods. Some vegans may obtain B12 from fortified foods like plant-based milk, breakfast cereals, or nutritional yeast. However, it can be difficult to consistently get enough B12 through fortified foods alone, so a supplement is typically recommended as a more reliable option. 4. Monitoring and testing. Regular blood tests. Vegans should have their vitamin B12 levels monitored through blood tests to ensure adequate levels are maintained and to adjust supplementation if needed. Early detection. Monitoring homocysteine and methylmalonic acid, MMA, levels can also help detect B12 deficiency early, as these markers tend to rise when B12 levels drop. Conclusion. Is routine supplementation necessary? Yes, routine vitamin B12 supplementation is highly recommended for vegans to avoid deficiency and its associated health risks. Supplements provide a reliable and effective way to ensure adequate B12 intake, supporting both nerve health and overall well being. Differentiating between anemia caused by folate deficiency, vitamin B12 deficiency, or a combined deficiency involves a combination of clinical symptoms, blood tests, and biochemical markers. Since both folate and vitamin B12 are involved in DNA synthesis, deficiencies in either can result in similar hematological presentations, like megaloblastic anemia. However, certain tests and symptoms can help distinguish between them. Here's a detailed approach. 1. Hematological findings. Megaloblastic anemia. Both folate and vitamin B12 deficiencies cause megaloblastic anemia, characterized by large, immature red blood cells, macrocytic anemia, with high mean corpuscular volume, MCV 100 Feflia. Peripheral blood smear. Hypersegmented neutrophils, seen in both B12 and folate deficiency anemia due to impaired DNA synthesis. Oval macrocytes, large red blood cells, can be present in both conditions, making peripheral smear alone insufficient for differentiation. 2. Clinical symptoms, vitamin B12 deficiency, neurological symptoms. Vitamin B12 deficiency uniquely causes neurological symptoms such as paresthesia, tingling or numbness in the extremities, memory problems, unsteady gait, and cognitive impairments. This is because B12 is essential for myelin synthesis in nerves. Glossitis. Inflammation of the tongue is seen in both B12 and folate deficiencies, but might be more pronounced in B12 deficiency. Folate deficiency, no neurological symptoms. Folate deficiency does not typically cause neurological symptoms, which can be a key differentiator from vitamin B12 deficiency. 3. Biochemical tests. Serum vitamin B12 levels. Low serum B12 levels, 200 pg/ml, indicate vitamin B12 deficiency. Borderline or low normal levels may require further investigation with other tests. Serum folate levels. Low serum folate, 2 ng per milliliter, suggests folate deficiency. Red blood cell RBC folate levels measures folate within red blood cells and provides a better indication of long-term folate status than serum levels. Homocysteine levels, elevated in both folate and vitamin B12 deficiencies, as both vitamins are required for converting homocysteine to methionine. This marker alone cannot differentiate between the two deficiencies. Methylmalonic acid, MMA levels, elevated in B12 deficiency. Vitamin B12 is necessary for the conversion of methylmalonic acid to succinyl-CoA. An elevated MMA level indicates a deficiency in vitamin B12. Normal in folate deficiency. MMA is typically not elevated in folate deficiency, making it a helpful marker to distinguish between the two. Combined deficiency. Both homocysteine and MMA may be elevated, with MMA elevation suggesting the presence of a vitamin B12 deficiency. 4. Response to treatment. Vitamin B12 supplementation. Improvement in neurological symptoms and hematological response suggests that B12 deficiency is the primary issue. Lack of improvement or partial improvement might indicate an additional folate deficiency. Folate supplementation. If anemia improves with folate, but neurological symptoms persist or worsen, this suggests underlying B12 deficiency. Folate can correct the anemia, but does not address the neurological damage from vitamin B12 deficiency. 5. Combined deficiency. Simultaneous low levels. Both folate and B12 can be deficient simultaneously, especially in individuals with poor dietary intake or malabsorption syndromes, e.g., elderly, alcoholics, or those with gastrointestinal disorders. Comprehensive testing needed. Testing for both vitamin B12 and folate levels, along with homocysteine and MMA, is crucial to identify and treat a combined deficiency accurately. Summary of key differentiators. Neurological symptoms suggest vitamin B12 deficiency. Methylmalonic acid elevation indicates vitamin B12 deficiency. Homocysteine elevation alone can occur with either folate or vitamin B12 deficiency. Response to treatment can help confirm the diagnosis based on symptom improvement or persistence. By using a combination of clinical assessment, biochemical testing, and response to treatment, it is possible to differentiate between folate deficiency, vitamin B12 deficiency, and a combined deficiency, ensuring accurate diagnosis and appropriate management.